Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. Today's episode is sponsored by Families Against Fentanyl. FAF is an organization set on breaking the status quo of failed solutions and to get to the core of the supply chain of deadly fentanyl. Learn more about FAF by visiting familiesagainstfentanyl.org and sign their petition to declare illegal fentanyl a weapon of mass destruction. Hello again, High Truths listeners. It's a pleasure to join you one more time for another addictive episode on drugs and addiction. I'm your host, Dr. Ronit Lev. I'd like to share with you a brief history on methadone clinics. Methadone is an opioid with a long half-life, discovered by German scientists in 1939. Hitler promoted national independence in drug supply from other countries, supporting the IG Farben pharmaceutical company that manufactured methadone. After World War II, German patents and other assets were distributed to the Allies. IG Farben was confiscated by the United States Department of Commerce. In 1947, methadone was approved as a painkiller in the United States. Fast forward from World War II to the Vietnam War, and heroin deaths rose to alarming levels. I was curious to compare what was considered alarming for 1960 compared to today. Deaths from heroin went up from 7.2 to 35.8 deaths per 10,000 population between 1950 and 1961. The government demanded drastic solutions. In 2021, the CDC announced a record 108,000 overdose deaths, about 22 deaths per 100,000. Deaths rose over the past 60 years so much that we changed the decimal point in the standard measurement method. In 2021, the death rate of 22 per 100,000 is massively more than the 1960s 3.1 per 100,000 when the United States decided to implement those drastic measures. And what were those drastic measures? The drastic measures came from a study from the Rockefeller Foundation, and their research showed success in treating heroin withdrawal with methadone. And that was the birth of our methadone maintenance treatment program we have until this day. In 2019, 408,000 clients received treatment at methadone clinics. And with that, let's hear our question of the day.
Hello, High Truths. My name is Tara, and I'm the Executive Director of the Harm Reduction Coalition of San Diego. Thank you, Dr. Lev, for caring and advocating for people who have a substance use disorder. There are many clinics here in San Diego that are methadone clinics, and I'm wondering if their treatment services are able to be expanded to include addiction services for other things such as methamphetamine use disorder. And here in San Diego, we have a huge need for that sort of treatment. So I'm curious to know if there's other ways that we can implement contingency management, wraparound services, and other things within methadone clinics to address other use disorders besides just opiates. I'd love to know your thoughts. Thank you so much.
Thank you, Tara, for your boots-on-the-ground outreach in community distribution of harm reduction naloxone and fentanyl testing strips. Thank you for your question on enhanced services by methadone and OTP clinics. We have a national leader to answer your important question, Mark Parrino. Mark is the president of the American Association for the Treatment of Opioid Dependence, AATOD, and he also serves as the vice president of the World Federation for the Treatment of Opioid Dependence and was the chair of the National Consensus Panel for State Methadone Treatment Guidelines. Basically, I consider Mr. Parrino the king of the methadone clinics. You can find Mark Parrino's bio on the High Truth show notes. Mark Parrino, welcome to High Truths.
Thanks for having me.
Mark, let's start with learning a little bit more about you. You started your career with a background in psychology and health policy, and what brought you to the advocacy field of methadone clinics?
Well, in 1974, out of college, I was looking for a position as a counselor and in what was called methadone treatment programs at that time. And it was a good fit. The administrator gave me the opportunity, and since then, I've been involved in this treatment system, so it's over 40 years. In all candor, I never expected to be involved in this for more than a few years, gaining some knowledge in how best to treat opioid use disorder. But then it evolved. I watched patients doing so much better as they entered and remained in treatment. And it was really remarkable to see the transformation, which you would see in the first month or two of care. It's people who were desperate, who really were at the end of their rope, became robust. They started returning to healthy behaviors as they stabilized. It was very impressive. And I've always been impressed by the patients. I think they're remarkable, their ability to survive. Clearly, the benefit to me was as you engage in this patient population, you begin to lose your judgments very quickly because it doesn't matter really how they got into trouble. Your role is to help them go through the process of their own recovery. And it's best to do so with knowledge and compassion, most certainly without any judgments. So that's part of why I stayed. I was always prodded by my colleagues to be in the role I'm in, which began with being the chairperson of the New York State program group, COMPA. And then I had this idea in 1983 to create this Northeast Regional Coalition among the 9 states in the Northeastern Corridor, which would bind and organize the treatment programs. And that would later expand in 1990 to a national group, and then about 10 years later to an international group.
So you really are, you have a robust career doing it because you're passionate about it. Most people in this field are very passionate about the issue of drugs and addiction. And I call you the king of the methadone clinics because you are the leading voice of advocacy. And I want to ask you, is that PC to call it methadone clinics, or is it no longer PC and it has different names of vocabulary? CSET
uses opioid treatment programs. Mm-hmm. So the Center for Substance Abuse Treatment, as you know, is part of the Substance Abuse and Mental Health Services Administration. They call these programs the opioid treatment programs, OTP.
All right. And can you tell us give us the current state of the union for opioid treatment programs, for the OTPs. How many do we have? How do they work? Give us a little state of the union of where we are.
Sure. Well, there's been an increase of about 400 OTPs from 2015 to the present time. So there are just over 1,900 opioid treatment programs throughout the country. Most of them, as you would anticipate, are in California and New York. But you have a large population of programs and patients in Pennsylvania and in Georgia, in the states in the New England area, and Texas and Florida. So there's really has been an expansion. There are still a number of states with fewer than 5 programs, like Alaska or North Dakota or South Dakota. And there's one state that does not have any program, which is an anomaly, which is Wyoming. In terms of patient number, we recently completed a patient survey, and which had an 85% response rate, which is, as you know, very good. And as of January 1st, 2021, which is when the survey was pegged, there were 1,826 programs in the country. So we sent the surveys out to them through the National Association of State Alcohol and Drug Abuse Directors, in combination with the SOTAs, otherwise known as the State Opioid Treatment Authorities. 1,547 programs responded, and about 514,000 patients were in treatment. In talking with SAMHSA recently, and extrapolating those numbers, we would say that it's about 600,000 at the present time.
Wow.
So the programs are expanding, and they're functioning. They got through COVID, which much in the way of challenge, especially in the first several months from March of 2020 to about June 2020. Those 3 months were very challenging. But the programs stayed open. They were seen for the first time as emergency medical facilities, which gave us the ability to order various supplies that we.
Right. I remember I was at the White House at the time, and you wanted masks, right? When there were no masks limits, you wanted to get authority to be allowed to purchase masks.
And you guys came through terrifically,
yeah,
because we were able to use the letter that the ONDCP director signed, and that was the basic element that started freeing up getting Clorox deliveries, mask deliveries, gowns as well. And without that letter, we weren't going to get it.
Right. And it's isn't it funny how things have come where we were so desperate to get masks, and now people don't want the masks. And just people forgot that.
Well, I haven't forgotten. I still wear my mask on a daily basis.
Yeah.
So, and with the COVID numbers going back up, I think that will chasten people once again.
Yeah. So tell us how these clinics work. Is it just for people who have opioid disorder? Is it just methadone? Is it government, private clinics? Tell us a little more what happens at those clinics.
So of the 1,900 programs, 60% are private for-profit entities. That changed about from 10 years ago when it was predominantly nonprofit programs. And as nonprofits would close, the proprietary programs would expand and fill that void. I'd say that of the patients in treatment, of the 600,000, about 80% use methadone, and the remaining 19% use buprenorphine, with 1% using naltrexone as patients exit treatment and prepare for basically not using any medication at all. It's a sort of good transitional medication. The reason for the primary use of methadone is simply based on most of the patients we're treating either have been using heroin or now more recently fentanyl, and about 80% of new patient admissions are using fentanyl. Since fentanyl is such a potent opioid, and the patients enter treatment with very significant opioid tolerance, methadone is typically the preferred medication because pharmacologically it does not have a dosage ceiling effect. It's a pure agonist. You can increase that dose until you achieve patient stability. That's the benefit with patients with a very high opioid tolerance. Generally, people who are using fentanyl and surviving have high opioid tolerance. We, of course, are seeing a large percentage of our patients who use other psychoactive drugs, either depressants or anti-anxiety medications. But the primary issue is stimulant use, especially when combined with methamphetamine. And as you know, medically, there is no effective pharmacologic treatment for stimulants. The pharmacologic treatments which are successful are for the opioid class drugs. But the patient obviously will come in for admission, then meeting certain federal and state criteria. The clinical practitioners at the OTP will decide to either admit or not admit the patients, and then treatment begins with the gradual buildup of the medication so that the patient adapts to the use of the medication. And it's, Howard Height, a colleague of ours, specializing in pain management, had a terrific statement about methadone, which he discussed about 20 years ago. He said methadone is a wonderful medication when it's used properly, but it is an uncompromising medication if it's not used properly. So in other words, the practitioner has to know what they are actually doing with the patient, because methadone has a unique pharmacologic picture, which is during the first couple of weeks, methadone in daily doses actually accumulates. So you have to understand that cumulative effect before you increase doses, which is why in those first several months of treatment, the patient is coming in typically 6 days per week so they can be observed. Once stability is achieved, then they are able to take home medication.
Right. And your statement about stimulants and other drugs brings us to Tara's question. Tara is a harm reduction specialist in San Diego County. I followed her one day to a homeless area in town and watched her give naloxone, fentanyl strips, and talk to people who have substance use disorder. It's pretty remarkable how she has a mobile van and goes to the community. And she notes that a lot of people in West Coast, and we're in San Diego, have a methamphetamine use disorder, and is wondering if there's any talk or movement for these OTPs to go beyond treating opiate use disorder to also methamphetamines. There is no medications, so it would be treatment with contingency management approach rather than medications.
Well, the programs have been addressing the issue of stimulant use because the programs are designed, as you know, to treat this disorder holistically with a comprehensive array of services, meaning the treatment teams at the OTPs, which include medical personnel, doctors, nurse practitioners, physician assistants, nurses dispensing or pharmacists dispensing, and a range of clinical personnel. And yes, by necessity, they've had to address, to the extent that it can be addressed, treatment approaches that embrace dealing with the stimulant use as well. And the reality has always been that once you stabilize the patient for their opioid use disorder, you can address the other issues. So the primary issue is how you get that patient stabilized with opioid use, which methadone does remarkably well, but you do have to address these other mental health and other abuse disorders. Also, keep in mind that a lot of our patients, at least 50%, are diagnosed with depressive or anxiety disorders. Mm-hmm. What we're trying to do there, too, is get the patient not to use those anti-anxiety agents that will actually create more problems. And I'll be candid from what the clinicians have always said, that's an enormous challenge in terms of patient care. It's like the patients, as you know, when they want to use certain drugs, they will use them. But we do our best to deal with those issues. It's much more of a challenge in treating the stimulant abuse portion than the opioid portion, which may seem counterintuitive, but that's our experience. But thank God for the harm reduction folks who are out there on the streets, in the shooting galleries, dealing with people who are not currently in treatment. Always the hope is that as a result of those harm reduction initiatives, that it becomes an opportunity to get the patients into treatment, because that's where the melding occurs. And when that happens, it's extremely effective.
Yes.
And that's always been our focus in linking the harm reduction efforts. And as I'm sure Tara must know, given her work, a singular administration of naloxone is generally insufficient, especially in dealing with people who have used fentanyl, which is why the first responder really needs to stay with that person before they go back into an overdose and hopefully get that person to an ER, at least for evaluation.
I agree with you wholeheartedly. Harm reduction really should be a way of connecting with treatment. And you're right, patients need multiple doses of naloxone. As an emergency physician, I've seen it play out several ways. Sometimes people get dose after dose and they're still not awake, and we wonder what's going on. And then the patient has, cocaine and methamphetamines and marijuana and everything else, and no opioids. It's like, okay, well, that's why it didn't work. Or they need multiple doses and it kind of works for a while, and then they go back under, and I need to admit them to the ICU on a fentanyl drip where they're getting continuous naloxone. So anybody who has any overdose, you should call 911 and go to the emergency department, because you really don't know what's going on, and let us stabilize. And I love the fact that you're speaking about the mixture and addressing the benzodiazepines and the methamphetamines, weaning off opioids. We have protocols of weaning off opioids is simpler than weaning off benzodiazepines. So the fact that you're bringing awareness to that and really discouraging people who already have a substance use disorder to become dependent and have a benzodiazepine disorder is important. I would love to see and empower all the OTPs out there to be able to treat benzodiazepine disorder and wean benzodiazepine as well. And that's another question. Are the patients who go to OTPs, some of them need to be in there for life, and being alive and getting treatment is better than the alternatives. But are there some patients who graduate and ask for weaning?
Well, the answer to that is yes. I remember going back to the 18 years I spent working in an OTP in New York City, that on any given time, I would say about 40% of the patients were trying to decrease their doses with the ultimate goal of being methadone free. And an interesting thing would come up, and this was corroborated clinically by many treatment programs. If the patient were on a dose of, let's say, 80 milligrams per patient per day, we would be dropping that medication every month or so by about 10 milligram decrements. And that worked well until we hit 40 milligrams. So somewhere between the 30 and 40 milligram mark, there was an interesting phenomenon. We'd have to decrease more slowly in 5 milligram decrements because the patient would have a greater difficulty in adjusting to the lower dose. They'd start having headaches, or issues of sleeping disorder would come back. And then once we hit 20 milligrams of methadone, we'd even have to slow it down even more so, or decrease much more gradually. Instead of a month, maybe take 2 months. There was an interesting study done by Rockefeller University easily 30 years ago. Unfortunately, it was never published. But it was a double-blind study where the researchers at Rockefeller would take highly stable patients who were 10 milligram levels, decrease them by 1 milligram intervals. And without the patient knowing what decrease they were having, they would actually experience changes in how they would sleep, levels of irritability, and that's only with a 1 milligram change in a methadone dose. So I know you're aware of this, but the brain is really quite sensitive, and we're in an area where we know lots about the other organs of the body.
I had another podcast where we talked about just benzodiazepines and weaning, and it's the same thing. For that, what you're describing happening with benzodiazepines, if you're on a high dose, going a little bit, 10 milligrams at a time, or benzodiazepines, it's less. But once you get to the final little bit, it goes much, much slower. Any small amount can, precipitate withdrawal and bad feeling or craving. And some people just need to stay on that little bit. And can't be weaned.
And that's true. And that's when many of the patients who would come in would say, I'm on this antidepressant, I'd like to decrease it, and just what you said. And then they get to a point that will say, you know what, I can't go, I can't do this.
Yeah.
And we've had a lot of patients, to the issue of those who graduate. I can tell you that you may remember the John Ball study, which was published in 1988. And Ball, it was a 3-year NIDA-funded study, the National Institute on Drug Abuse. And there were 6 programs in 3 cities, New York, Baltimore, and Philadelphia, that were part of the study. What Ball and his colleagues did was track the patients as they left treatment, either voluntarily or through discharge. And within 1 year of that last dose of methadone, 82% of the patients had relapsed to pre-treatment heroin use. So, and by the virtue of that study, you might infer that 18% of those individuals were able to remain methadone free. Now remember, the study tracking ended after a year of leaving treatment, so we didn't have a longitudinal analysis of how those patients would do. So, but generally speaking, our experience has been the majority of the people will need to be in treatment for an extended period of time. That can be 2 years or 3 years or even 5 years. And as you stated, for some of those people, they will remain in this medication for the remainder of their lives. And from our point of view, it's like treating any chronic relapsing disorder that needs a medication-assisted value, whether it's diabetes or hypertension. And in this particular case, as patients go through that struggle, because remember, it's a stigmatized medication, and employers or families will bring great pressure to bear on a patient. And I remember in the treatment facility working with many of the families of the patients to try to get them to understand brain chemistry or why their family member is doing well. And then sometimes the family member or employer would, let's say, win the day, for lack of a better way of putting it. And then our job at the program was to always say to the patient, if something goes wrong, or if you can't sustain your sense of being drug-free, you can always come back and we will welcome you as you need. And that's where the lack of judgment comes in.
Yeah.
It's not good to ever castigate a patient. It just is not, it does not work in the long term, and harsh policies simply fail.
You know, I start people on buprenorphine, not methadone. And when I do that, I get a history of their drug use. Invariably, they started with marijuana at a young age. But I want to know how long they've been, because then I could explain to them, your brain has been used to high dopamine levels now for 10 years. Don't be so quick to stop buprenorphine. Don't use it just for withdrawal. You may need to be on it, and depend on how long they've been using drugs. But you've been using drugs for 10 years. You're not going to probably retrain your brain not to need it within 2 weeks. You may need a year, or more. But the patients I run into kind of feel like they just need it for a short amount of time, and I want to get them to start thinking that this is not good. This is not just a short-term fix because they're in the emergency department. I'm starting you on a long path, to not just to treat your withdrawals, but to train your brain, on the cravings. Or maybe less. If I had a patient yesterday with terrible withdrawals, high dose fentanyl, but she was only using for a year, and I thought, well, you know what? You may not need it for your whole time, but use it at least for a few months, and then before you think about weaning.
Well, but remember, you're an experienced clinician, and this makes all the difference in the world. By the way, where you have experienced clinicians, you're able to provide better guidance to the patient, and explaining why a medication is a maintenance medication is not so simple. And you have to spend time with the patient to explain this. And, sometimes I remember when patients were being admitted to treatment, there was not a feeling of exhilaration at that time of admission. There was a sense of, I'm at the end of my rope. I feel I have no other alternative. Sometimes the patient, we were explaining, this may be a long-term treatment. And then we had to carefully say, but we don't want to discourage you.
Yeah.
Yes, this may be long-term. Let us see how you do. But it's your point exactly. If the patient is coming into treatment and they're 25, they've been using various drugs since they're 13 and 14, the concept of, we're going to give you a medication for a short period of time, several months, and that should do it. that does not happen. And all of the NIDA-funded literature in this topic indicates that those relapse rates are incredibly high, which is why treatment has to be open-ended. When sometimes people will ask me, so how do you know treatment is over? I said, well, that depends on the stability that the patient has achieved. It doesn't matter what dosage they're on, as long as they're stable, they're doing well, they are functioning as an adult in a society where there is an expectation that you are going to function and contribute, whether it's through a job or training, but you're doing something productive. And for some, and then you respond to the patient. It's almost all of the treatment is completely voluntary. Patient comes in on their own. And if that patient says, look, I think I'd like to try decreasing the dose, you do it. And then you work with the patient over the course of time. But you're right. There's been a lot in this, and I realize that you're aware of this, where sometimes the programs themselves don't really understand the maintenance benefit. So sometimes you have clinicians saying to the patient, look, you've been doing great, and you don't have any drug use, and your counseling is doing well. Maybe this is time to consider. And I understand that approach, but I think this is always a patient-driven matter.
I actually thought it was the other way around, that there may be a financial incentive of the clinics to keep patients on.
Well, it's, and that's come up a lot too, especially if you're talking about these so-called profit-making entities. Mm-hmm. And the answer is, there's nothing to suggest. I mean, there were some books written years ago, and there was a chapter on this topic. And the issue is, well, isn't there a financial incentive to retain the patient? And the answer is no, because there are so many patients that need to be treated. So in effect, it's not like you're trying to hold on to the person because there's so many people that need access to care. And basically, have I heard of programs discouraging a patient from withdrawing their medication because there's a financial benefit to OTPs? Yes, I have heard that. Mm-hmm. Is that what I would perceive to be a significant phenomena? It is not.
Okay. Fair enough.
Which is good, because aside from being blatantly unethical, it's also, that's why I said if the patient basically says, I want to try to leave, great, let's work with you. Let's see what happens.
Yeah.
And again, without judgment or without compromising the integrity of the treatment experience.
So, Mark, I'm going to change the topic to something where I don't know that you and I agree on, which is okay. But let's talk about. I've been pushing to X the X waiver, and I think that you think education is important. Let's talk about that. What do you? First of all, what has been the effect of opening up buprenorphine to more practitioners on the OTP clinics? Has that affected your volume of work, or has that made more of your clients want to switch from methadone to buprenorphine?
No, it's generally the patient's decision. I mean, as I said, 80% of the patients in our treatment programs use methadone, only because that's what seems to work most effectively with these patients, given the kind of drugs they're using, mostly fentanyl, but also heroin. From our point of view, there's a real interesting difference about patients being treated in an OTP. You're dealing with a team of health professionals, not one or two folks, which may comprise a typical Data 2000 practice. That's one difference, which has nothing to do with pharmacology. The issue of training is an important one in the sense that the doctors will be able to treat a certain number of patients. No one's done any real comparative analysis of what happens to patient outcome depending on the different categories that SAMHSA has approved. So as an example, there are Data 2000 practices that treat up to 30 people.
And let's just clarify to our listeners, Data 2000 means doctors who have an X waiver who are allowed to prescribe buprenorphine.
Correct.
Okay.
And that's been in existence for over 20 years now. And so there are classes where certain doctors can treat up to 30 people, certain can treat up to 100, and others that can treat up to 275. We're not really sure of how the practices function because SAMHSA has not released any data collection about what services actually transpire within those practices. They did publish a federal register notice, which would have given them the authority to do it, but they were concerned about executing that sort of one-year survey, which would say how many patients are in treatment, what kind of counseling is offered, what are the results of toxicology testing, things of that nature. Because interestingly, over the 20-year history, no matter how many practitioners were waived, very rarely do you have more than 50% of the waived practitioners who actually took the training involved in active prescribing. It's very interesting. It never goes beyond that. So what's happened over the course of 20 years, more practitioners have been added, whether it's mid-levels or advanced nurse practitioners or physician assistants. And that has certainly bumped up the number of active prescribers. About a year ago, Health and Human Services did give the opportunity of practitioners to treat up to 30 patients without training. And since that time in the last year, about 12,000 practitioners have taken advantage of submitting an application without the training. And most of that, according to SAMHSA, about at least 75% are emergency room practitioners.
I was just going to tell you that. It's all of us. We've been hounding on our colleagues in emergency medicine, so we're able to do that.
Right. So, I think that what we keep saying to SAMHSA is it would not hurt for you to really get a sense of what is being done within the practice. According to the American Academy of Addiction Psychiatry, which does a lot of the training for Data 2000 practitioners, they've advised us that after the training, many of those people who go through the training want mentoring and actually want even more information.
But Mark, have you taken the training?
Oh, I'm not a
right. I have. It's 8-hour training. It's supposed to be 9. After that, I had more questions than answers, and I wanted to eliminate the training, and I really made a case for that during COVID, and that's when we opened up prescribing, because COVID came onto us. I didn't know what I was dealing with, and I had to learn on the fly, and that's what we do as emergency physicians. Didn't need 8-hour training before treating COVID. I didn't feel like I needed training to treat opiate use disorder. And I think we've seen now, like all these emergency physicians who got the waiver to treat, we're able to train our providers, and they're able to treat now opiate use disorder. We didn't need. I've been a doctor now for over 30 years. There's always new things on the horizon and old things that need to be discarded. And we have ways of learning that in medicine without forced education. I would say forced education got us into this problem. There was, 20 years ago, doctors were forced to learn how to treat pain better. And that created more doctors giving more opioids, right? And so training can get you into trouble also. So I think that the X waiver is stigmatizing, actually, because it's like, oh, doctors could say, oh, well, I don't treat those patients. They have to go somewhere else, right? It's like, wait a second, don't you treat asthma? Don't you hit high blood pressure? You need to be able to do the basics. And I think treating opiate use disorder with over 100,000 people dying a year of overdoses should be something every doctor in America should be able to do. And yes, some patients need a specialist, and I think that's where you come in. You are perfectly, if I need an endocrinologist and the primary care doctor can't treat my diabetes, you go to the endocrinologist. I think you're like the endocrinologist for substance use disorder.
Well, I think the issue here, though, as patients are presenting to treatment, from my point of view, and if you listen to the patient advocates, and it's very interesting to me, the two large patient advocacy groups are NAMA Recovery, which basically have methadone and buprenorphine patients within their organization and on their board, and then Faces and Voices of Recovery. when you talk to their various leaders and boards, they basically take the view, we want to be treated by trained practitioners. We want to be treated by people who know what they're doing in case we get into some really strange areas. And fentanyl may be one of those particular areas. And so from a patient advocacy point of view, their point of view, they prefer the trained practitioners treat them. Now, I understand what you're saying, by the way. Mm-hmm. Can physicians who are effective, knowledgeable, understanding, can they really understand how to treat such patients without an 8-hour training? The answer is probably yes. And then the question becomes, what are the attendant dangers or risks of doing that? And again, I would love to see a NIDA-funded study that says, all right, this is the group of practitioners who use buprenorphine without training, and these are the ones that had training. Is there any change in patient outcome?
But Mark, there's no precedence for any other disease process to be treated that way, right? So I think you and I agree that if you have a substance use disorder or you have heart disease or asthma or high blood pressure, you deserve compassionate care and medical care. And we're trying to unstigmatize the disease, which means that if you have a patient in your practice who has, ulcerative colitis, and they also happen to have a substance use disorder, at a basic level, every doctor should be able to treat that, just like at a basic level, every doctor should be able to treat asthma or diabetes. And then some patients have a harder problem, and that needs a specialist, especially since we have so much of that of addiction in our country now, and we need more providers, and I don't think it's that hard to treat. When I talk to doctors, I said, listen, you've learned how to treat COVID. You've learned, I've learned how to do all sorts of difficult procedures after my medical training. You could learn how to do this.
Well, and as I said, I think that's true. I don't know to the extent of how true that is in the long term. And again, the interesting instruction is that even with SAMHSA waiving about 121,000 practitioners to the present time, you still don't break 50% of the practitioners involved in active prescribing. That's an interesting issue, and that needs to be better resolved. Is that because they're in isolated practice settings? Is it because of pre-authorizations from third-party payers? It's because they are interested in treating this disorder, but when it comes down to it, they prefer not to.
There's probably a little bit of all of that. I went to a conference and I said, you know what, everybody here needs to have an X waiver. You can learn how to do this. It's not that hard. Here's an advice line. And after the conference, I had several physicians come to me and say, you know what, I've had my X waiver for a year and I can't use it. I need to use it. And the reason was that they didn't have the backup. Okay. So as emergency physicians, who are the majority of the people who got the X waiver recently, you can start treatment, but you have to have follow-up, right? You can't just, start a treatment and have no one to follow up. And there are still communities out there. And that's why I think it's so important to get primary care physicians on board and remove the barrier of registering with the government. You don't have to register with the government to prescribe oxycodone. You shouldn't have to register with the government to prescribe Suboxone, and that would eliminate the barrier and really be a calling for every primary care doctor. Like, you owe this to your patients. You're treating their diabetes and high blood pressure. Don't ignore their addiction. You're able to treat at a basic level, and if you need a higher level of care, then you can do that.
No, I understand. I think the point here, and you've made it, when you looked at Vermont, because Vermont, in all of the states, had a very high percentage of their practitioners as using buprenorphine through the data waiver process. But what Vermont did is created an interesting hub and spoke management model, where they would be sure that the physicians and other medical practitioners who were using buprenorphine had clinical backup services basically entwined in their own service delivery. And what that did is actually had those practitioners remain as active prescribers over a very long period of time. Contrarily, if you went to North Dakota several years ago, the buprenorphine doctors, there weren't many of them, but they were feeling overrun and they were feeling exhausted by the fact that they just did not have the ability to provide those wraparound services.
Yeah.
So a lot of those practitioners felt isolated and they were burning out quickly for that matter. So I think that from my point of view, training is a component, but you have to look more holistically at the context of the treatment environment itself. What's really offered? And look, if Congressman Tonko's bill is passed by Energy and Commerce next week, we may have an interesting change in that no one will be receiving training, and then we'll see what happens.
But Mark, I don't think anybody won't be receiving training. It just won't be receiving training through the government mandated 8-hour course. All the ER doctors who are providing buprenorphine, I would guarantee 100% of them have received training. It just won't be the kind of training that you can document in a government way. They learned how to do it.
Well, we will see, is generally my view of these things.
Yeah.
You know, right now there are people who have an interest in giving doctors prescriptive authority for methadone.
I want to ask you about that. What do you think of that?
Well, we think it's potentially quite dangerous.
I think so too, actually. I agree with you on that one.
And there's a reason. Well, but if you explain this to congressional members or their staffers, there's a bill that would authorize this if it would go through. And what I have said to them is, look, methadone is an interesting medication. Buprenorphine is safer to use because there's less risk of overdose, given the pharmacologic properties of buprenorphine. Methadone, because it's a full agonist, and because it accumulates in the system for especially people who have low opioid tolerance, so you have to watch that. But we have an interesting experience. When, as you mentioned this, when doctors are more actively treating pain in their private practices, interestingly, not so much cancer specialists, but general practitioners. And as they treated more of their patients with methadone, especially as a first-line pain management medication, which is completely unwise.
People died.
And at large numbers, where there were, starting around 1998, and then for the next 15 years, there were 6,000 plus methadone-related mortalities per annum. So much so, and you know this, given your prior positions in federal work, that there were 5 national methadone mortality reports that were published. 3 by SAMHSA in 2003, 7, and 10, 1 by the U.S. Drug Intelligence Center, and another by the General Accountability Office. They all arrived at the same conclusion, by the way, which was the prescribing of methadone for pain through distribution of general pharmacy channels was the primary reason those people were dying.
Absolutely.
So this is like an established fact. We don't have to speculate what this is.
Right.
And every time I have pointed to those studies, I find it quite interesting when people will push back and say, but Mark, that's different. Methadone prescribed for pain is different than methadone prescribed to treat opioid use disorder. And so my question is... It's
the same drug. When people are dead in the morgue, it doesn't matter why they were given it to them. They were dead.
Yes, I have used very similar language in response. It says the same thing. You know, when you have somebody who's deceased, you're not able to solicit, by the way, was this because of pain management meds or addiction treatment meds? Which was the causation of that? And I think but that's where you get into these areas of policy versus clinical care. And I've seen this divide, and this is very interesting to me, frustrating, but interesting, which is you take a public policy approach and it's on one side of the fence. Then on the other side is, how do you treat this patient population clinically? Now, one would argue, as I would try and have, that good policy will lead to good treatment interventions. And policy, contrarily, that's not that wise and that has unanticipated and negative consequence will lead to destabilizing the system. I have an interesting 40-year insight into this because longevity does a very interesting thing for you, as long as you pay attention. And in my circumstance, having a 40-year trajectory, I've learned what works and what doesn't work. And I've learned where to be cautious and where to think more liberally. And frankly, I think the COVID-19 realm did a very interesting thing, and it's having its ramifications play out, which is OTPs have been enormously conservative about giving patients take-home medication. And they've been incredibly conservative, and they have functioned in a regulatory environment since 1974 at the federal and state level. It would be interesting to note, as more take-home is provided and it's done with good clinical care, I think we're going to see patient retention rates increase. Because I know from a patient's perspective, frequent visits to an OTP is laborious. It's difficult.
It's why people want to do buprenorphine. I was thinking that you're having people want to switch because they'd rather go to a doctor's office rather than an OTP because they don't want to have to go every day.
And that's true. That is true. It's not a large percentage given the nature of the history of opioid use by the patient. But there absolutely are patients who either leave methadone treatment to go to a buprenorphine practice for this reason, or alternatively stated, I think there are a large number of people who would prefer to be using buprenorphine at the beginning, not setting foot in an OTP because of the word of mouth issue of restrictions.
Yeah.
But I do think as we go forward, I know that SAMHSA is now in the process of reconsidering elements of their OTP regulatory oversight. And then we have to see where that falls. I think they're going to be doing this by the end of the current calendar year. And then the next interesting question is, if the federal authorities make treatment less subject to very strict regulatory oversight, then the question is, does that translate into how the states, which have their own regulatory mechanisms, will do that? And then, of course, the OTPs and treating the patients. So that's what makes this very complicated from a policy perspective in tying together federal agencies, which have jurisdiction in the area, and then, of course, the interplay between federal and state agencies, and then, of course, the OTPs and the patients.
Yeah, makes it complicated. To add to your danger on buprenorphine, you probably didn't run across my study. I call it the death diary research. I did it just in San Diego County, working with the medical examiner for several years. I looked at every single person who died of a medication and compared it to 12 months worth of prescriptions from the PDMP. And that raised my alarms on methadone deaths, because usually people died of a cocktail. 80% of people who died of a medicine didn't die of just one. They died of multiple. But if there was one drug that would just, instant kill by itself, it was methadone. And out of 46 patients who died of methadone, only 6 did we find any prescription in the PDMP system. So that means that they got it outside the PDM system, either in the streets or methadone clinics. The other thing that I see that, we really, based on that research, we really reached out to OTP clinics in our community and asked for several things. One is we asked for naloxone for, anybody who's on methadone should have that. The other thing is to check for QT intervals, because I've treated, it's not a rare thing to see people who have sudden cardiac death from long-term use of, or even short-term if you have a reaction to methadone. So it's preventable if you just check EKG, and also to check the PDMP system to see that people aren't double dipping with other places. I don't know if you agree with that, but I do agree with you. There's different levels of care, right? We have levels of care in the emergency department where I say we shouldn't have any barriers to start people with addiction treatment and refer to the primary care doctors. There's a primary care doctor's office that should be able to do basic level, like I mentioned, of treatment of addiction. And then you need sometimes patients need a higher level of care. They are not meant to be treated at a primary care doctor. And that's where an OTP clinic comes in, or an addiction psychiatrist. And I love the wraparound services and strictness that the OTPs have, because if a patient's not working out at a primary care doctor, they're not able to follow or be helped, or still using, then you could say, you know what, this isn't working here, but I'm going to send you here to this other clinic.
Well, I would agree. I think that gets to the issue of how smoothly a system of medical care really functions in integrated models. And I think still you see various pockets of isolation. It depends on the city and the state. It depends, interestingly, on the size of the state. So smaller states tend to be better able to track the interplay between how OTPs can refer to practitioners and the opposite. But they need to be known to each other. It's
Yes.
sort of an interesting,
Yes.
I know this sounds really strange, but if it's not unusual where you have practitioners who don't know if there's an OTP around,
Yeah.
or there's an OTP to refer to, for that matter. So, and that gets into the issue in Vermont.
I don't think that's strange. I think that's common, because doctors aren't used to working outside the confinements of a hospital. Either I have an orthopedic doctor in my hospital or I don't. They're not used to working with community resources, which is something that we're doing with the issue of addiction.
And that's correct. And I do think, and we have policy recommendations that stretch back to 2011 that says to the OTP, you should be checking PDMP websites. You should be doing that.
Yeah.
And there's a reason you should be doing it, because you want to more effectively treat your patients. And we did some pilots, interestingly. We did it with several programs in a number of member states of AATOD. And I was particularly interested in what happened in these programs. And this was written up, interestingly. And basically, the staff would meet with the patient and say, look, we are going to check PDMP databases. And this is what the PDMP database is. And this is what we're going to look to see. Would you please tell us any medication that you're using now? Either you're getting through doctor pharmacy or you're buying from the street. Nothing will happen to you. There will be no untoward effect of any kind.
Mm-hmm.
Nothing. Please advise us now. And the program in participating in this had to query every one of their active patients. And then, so you would think that, okay, this would be an opportunity for the patient to say, this is what I'm using. 25% said, I'm not using a damn thing. And of course, then the program started checking the PDMP website, and they found that of that 25%, almost all were using something, because they had to explain that, well, wait a minute. If you're saying you're not using anything, how do you explain this toxicology report?
Yeah.
And then it started coming to light. Some of the patients, there were programs where there were patients doing a very active business in buying other people's urine. So, there's an interesting issue here. I think this is a very important disorder to treat effectively. I think these patients really do need to be encouraged to get into treatment, then to remain in treatment as long as they benefit from its continued use. And certainly the system of care needs to be better integrated. I think that it's a two-way street. There are OTPs that have stabilized patients. They should be able to refer those patients back to a medical practice setting.
Yeah.
And I think it's true the other way around. But we're not there yet.
We're not there yet. We're working on that. And that leads to my next question for you about privacy issues. There are different levels of privacy when it comes to addiction and mental health, right? So we have regular HIPAA protection, and then there's a super duper protection for people with mental health. And that creates another barrier. I think it creates another stigma because patient comes to the emergency department and they need to get their appendix out and they say, oh yeah, I take methadone. I should be able to see that. Right now what I do is I wait till the next day, call the OTP clinic. We have a relationship. They're able to tell me the dose. I could confirm it. And then I could be a better doctor. But that level of privacy, I think, interferes with collaboration and bidirectional integrated treatment.
I understand, but in this particular case, the patients are the driving voice. Interestingly, not the medical industry, not anybody else. These patients have said unequivocally in the organizations I've talked about, NAMA Recovery and Faces and Voices, they do not want their identities revealed in being in treatment unless they have signed a consent to do so. And why is that? Because they are so stigmatized. Does the argument apply that the confidentiality protections enhance the stigma? I don't see that argument, frankly. On the other hand, patients have been terrified, and they have reasons.
Yeah.
Because, you know, once a patient is identified, they can't get life insurance. Many of them can't get health insurance. These issues come up in child custody battles, where opposing counsel will say that person's on methadone, therefore that person's an unfit parent. And then the family court makes decisions accordingly. If you listen to the patients, they will tell you stories of as soon as they tell.
But the court shouldn't have access to HIPAA protected information.
The court when it comes, the court will then take in any evidence that comes in by either counsel. And if one counsel finds out the status of a person, which comes through their clients, they announce it. They basically say, by the way, this is what's going on.
I understand that, but the level of protection doesn't fit that argument. They're going to find that out from wherever. That shouldn't be a reason that, you know, medical professions shouldn't be able to talk and share data.
But the issue here is what do those clinicians do with the data? Also, keep in mind PDMPs, at least 30 of them, share data with enforcement people. And I know that in certain states, as enforcement folks get access to information about a patient being enrolled in an OTP, you will have squad cars going up in front of that OTP waiting for that patient. That does happen. And so the question here...
Well, that's something... That needs to be fixed.
It's not going to be fixed. That's an illusion, because that is embedded when a southwestern state had the director of their PDMP say, we want all of you programs to come into PDMP registries.
Yeah.
And then the program said, why are you so anxious to do this? We want to cross-match this against outstanding warrants.
Oh.
So, okay, you could say that shouldn't be. It shouldn't.
Mm-hmm.
But you have a lot of different entities that want to get access to this patient's information. And it's not always for good reason. So I really do understand the conundrum. And I recognize the difficulty.
Well, perhaps, I don't know. I hear what you're saying, but I think there's solutions that we won't fix in this podcast. But I mean, if PDMP were to become healthcare data, not law enforcement data, then that would be a way for us to be integrated. Or, I mean, I think there's other solutions.
It could be, but right now, you know, there seems to be an appetite for commingling patient central registry data, which basically is collected by a state entity or its designee, to prevent multiple patient enrollment in an OTP, which is good. And these patient central registries have worked favorably for many years. Mm-hmm. The interest of commingling those registries with PDMPs creates a different problem. And look, as long as the consent feature continues to operate, the patient ultimately should be in control of where their information goes. And then if the patient says, sure, I want people to know, that's okay.
But if we learn from history, and to bring your longevity analogy, I remember the AIDS epidemic, right? And you do too, where that was super sensitive and doctors weren't allowed to know if their patients had AIDS or not because it was like super secret. And so at the beginning, having HIV was very stigmatizing. And I would say now, when we don't have those barriers, those patients are getting much better care with less stigma. And so I see a similar analogy to the issue of treating substance use disorder.
I think substance abuse disorder is quite unique, and I'm not sure of how stigma changes or improves. I'd like to think that there is the beginning of a wider acceptance with less judgment, given how many people are using opioids or dying from opioid use disorder. And this sort of, there's an interesting sort of issue. Mm-hmm. As you know, we just passed the 1 million mark of COVID-related deaths in the United States. Mm-hmm. And still, and in spite of that, millions of people will not get vaccinated. So you have these mounting mortality figures, which would certainly drive me to get vaccinated, and I have. But it's interesting that there are millions who basically reject that. You have over 100,000 people dying of opioid use disorder, but there is still a great reluctance to engage in treatment.
Yeah. I think it's
interesting phenomenon.
It's a little different. I think the COVID crisis happened at a peak distrust of government and a peak distrust of pharma, and caused people not to have vaccines. I ask every single patient. I see 30 patients a day. Are you vaccinated? Are you not vaccinated? And the people who are not vaccinated don't fit a profile. They're not far-right Republicans, okay? They're not young or old or black or white. They're all over the place. So I think that's been a terrible gap in this COVID epidemic. Different than substance use disorder.
Well, they are different. I do think that substance use disorder is in a very interesting sort of place. It may change into the future. It may change. And I've certainly asked our federal agencies, including the current administration at ONDCP, to really think about a national public education campaign. Because we've never really had that, certainly not in any sustainable way, that says to the American public, look, this is how people get into trouble with using opioids. There's a sort of trajectory. You get pills, you take more of them, you start chewing them, or you snort them, or you inject them, ultimately.
Wait, let me ask you, Mark, where do you start? Because I see, and we talked about this before, I see we don't start with pills. You start with marijuana when you're 12 years old.
But, I think that whatever that sort of prevention-oriented campaign will be, marijuana, alcohol, which are both readily available, and then the trajectory that gets into various opioids, pain pills, which are easier to get. Interestingly enough, that the rate of prescribing opioids to treat pain has declined, and that year of declination was 2018.
Yeah.
And when you go back to 2018, that was the one year you had fewer opioid deaths.
Right.
It's sort of, there are interesting sort of elements in this.
I wanted that job at ONDCP because I thought that, I could help make that happen, because prescriptions from doctors is a very finite population that I have, a good language for and know how that system works. And I knew that the prescription opioid epidemic would end. And it did. I think we're done with that. But now we have much worse problems.
Well, that's right. And there was a sort of connection to it. We mentioned this to a number of federal agencies. As you may recall, our association manages 75 program and their admissions in 30 states. This is part of what's called the radar system, which is managed by the Denver Health and Hospital Authority. So in our 75 participating programs, we begin this data collection in 2005. We continue to do this to the present, with over 135,000 patient surveys basically having been analyzed. After about 4 years of collecting data, in 2009, we noticed an interesting trend. And you notice you need a few years before you can call it a trend. And what happened was interesting in that third to fourth year, some of my staff came in to say, because they were monitoring the data with other epidemiologists, they said, look at these numbers. 45% of our new patient admissions are coming to treatment because of prescription opioid use. I said, well, we know this. I said, okay. Of that 45%, 30% are injecting their prescription opioids. Now that's new. That was new at that time in 2009. And I was concerned about that because I thought, I'm looking at the ethnic sort of numbers here, and about 80% of these patients are white, and they're reporting good incomes in the collection that we're doing the study. So then I go back into Washington, and that environment all too well. I start meeting with the federal, all of them, ONDCP, FDA, DEA, NIDA, SAMHSA, HHS.
You get around, Mark.
And,
they all know you.
So that's the other value of longevity. I'm sort of seen as a stable, sort of continued person who deals with this. And, they understand that I really do want to see people get access to good care. That's my interest. And then everything is related to that end point. And because they deserve to get access to care and good care with that.
Yeah.
But I think so. And what I would say to a number of the federal officials, and I'm not beating on them, this was what happened. I'd say, look at these data. These data are revealing. Does this mean that as prescription opioid abuse eventually declines, that we will see rises in other areas of opioid use? I said, no, I don't know when that is, and I can't predict that. But I'm just looking at the fact that of these 45% patients using prescription opioids and then needing treatment because of that, and 30% of those people are injecting their prescription opioids, I think that's like the canary in the mine shaft. I would pay attention to that because I think it basically portends that something may be actually changing. Now, I don't think I'm that smart in recognizing this. I think it's a matter of connecting the dots. But once those dots are connected, they stay. And I think that the next question is, when do we leave this third wave of opioid use and go into the fourth wave, whatever that may be? And of course, as you know, the current problem is that, and it's very unusual historically in this country, because historically, David Musler used to write about this in his work, and he would generally say since the late 1800s, increased opioid use precedes stimulant abuse. So he's documented that in his writings. But now we have concurrent.
I think that's dependent on availability, on supply. Like that's not true for the West Coast, right? We have people.
I'm talking about going back 100 years and then going back 80 years. Mm-hmm. Not now. Now you do have cross currents, which are frankly dangerous. I mean, when I was in the clinic, when we were treating opioid use disorder, yes, you'd have heroin, and the patient was also using cocaine. And the notable speedball effect, like the central nervous system depressant, but you want to come back up too. And nothing brings you up as much as a really good stimulant. And, and when I was younger and less experienced in the 1970s, what I call my young and stupid period, that, I remember asking a patient, because I didn't know, and I would say, how come you stabilized on methadone? I noticed you're not using heroin or anything. Why do you keep using cocaine? And the patient just looked at me like the idiot I was. And he said, because it makes me feel good. He said, okay, I understand this. I said, but it's not helpful to you. And then as you would say, you'd have to work through that, engage trust, and start treating the patient holistically. But the real point I'm making is that we do have a dreadful problem with the opioid mixed with these powerful stimulants, which goes back to your original question of, shouldn't the OTPs be treating and dealing with this? And the absolute answer is yes. Yeah. Because we're responding to the needs of the patient.
I see you greatly. I've said this before, that to boost the services that you do. I see you as the specialist in substance use disorder. When another higher level of treatment, then you are the highest level of treatment for, and it should be for anything related to drugs, whatever drug that is.
Well, we have two significant challenges at the present time. One is the third-party insurance reimbursement, which doesn't always recognize the need and value of responding holistically to the patient. And because they will say, wait a minute, there's only so much Medicaid reimbursement funds available in our state. We're going to create some arbitrary decisions.
Well, that's why we need to integrate you with the medical system.
Well, I'm not opposed to integration, by the way. I think that the systemic design has to be piloted, so you get a better understanding of how it functions. And then the other problem is, like so many healthcare providers, we are facing some wicked staffing ratio shortage. Yeah. I mean, so I agree with you. Conceptually, yes, we want to increase services to the people, respond to their needs. And then there are the limitations of, and are we getting reimbursed for these additional services? Yeah. And then can we find the quality of the worker to come in? And that's, we're having problems with physician shortages, nursing shortages, counselor shortages. Yeah. And I'm hearing this from all over the country.
Right. In all the fields, right?
All of these fields. And so I think that as we move past the realities of COVID infections, and we will get there for sure. And you can see that aside from the fact that there are these current spikes, but I tend to be optimistic about these issues. I think that you have to steadily chip away at these challenges and these problems.
Yeah. But it'd be nice if we I see that you're absolutely right. I see this is the gold standard that I'd love to have happen. We're not, and then like you say, bring us down to reality. We're not there yet. But if we had a common vision, then eventually we would get there.
I would agree, but you also need a sort of multi-year issue of both working with central federal leadership and then working with states in order to achieve these sorts of goals. And you really need to have a better interplay with third-party agents. It's always interested me that even when you get into our area, where state alcohol and drug abuse directors who deal with our system don't necessarily work hand in glove with the reimbursement authorities in their same state. Yeah. Now, I think that there's an increasing awareness, even with criminal justice, which is a big one. New York State's legislature recently passed a law that stipulated that all correctional facilities in New York State will have to provide medication-assisted treatment for overuse disorder for their inmates with a referral to the OTP's ordained 2000 practices.
Makes sense to me.
Exactly. And I think other states will follow. Yeah. Now we have to work out the mechanical details of how that vision is achieved. Yeah. So that means you need to have the corrections folk talk to the OTP folks and their respective state offices so that this can actually be put into action. Right. And look, the DEA recently, in June of 2021, finally passed that rule that OTPs could open mobile van units, which could then reach out into the suburban and rural communities.
Yeah.
And they're doing it.
Yeah.
More of these vans are happening. So, that's in all of the issues we've discussed. I continue to be encouraged by these changing features. But I also know the mechanics behind it. Sometimes, and you know this, changing federal and state policy is like pulling deeply rooted wisdom teeth.
No, much harder than that. My husband's a dentist. It's wait.
Well, I would tend to agree. I'd say I was understating the challenge. I worked on the mechanics of these issues.
Yeah.
And as you know, the broader reaching the vision, the longer it takes to get it even into the pipeline. And it's which I understand too. In my position, you need to have a mixture of patience with urgency. And they're competing. That's quite a challenge, because you have to be patient enough and secure enough to understand that these things will happen, but urgent enough to kind of move it along, because there are lots of factors that get in the way.
Right. I want to kind of close and get your perspective on the issue of stigma. I think people say, oh, we don't want stigma, we need to eliminate stigma. But people don't make the careful distinction between stigma for the user, the human being who has a disease that requires compassion, versus stigma of the drug and the use. And there is a movement to normalize drug use, saying, okay, well, I use drugs, so what? It's okay. Stigma got us out of people who smoke. There's stigma of smoking cigarettes. Not for the user who has an addiction, but, it's not cool to smoke cigarettes. And yet I see some parts of our society philosophy that's going beyond stigma for the user to remove stigma from using, that it's okay to use. And how do you see that?
I think that's a real evolution. And I think there's a sort of uncertainty as that drives forward. As an example, there's an interesting issue of, in a harm reduction approach, where you set up safe injection sites. And I remember that when we were opening OTPs, if you ever wanted to see a community organize and get close, tell them you're going to open up an OTP in their community. Suddenly people who would never talk to each other or despised each other are all saying, yeah, we've got to get this general counsel involved and we're going to go fight that program. And I think the same thing is applying when these safe injection sites come up for consideration in community. I agree with you. I think the stigma associated with the drug versus what happens, or how that translates into the stigma to the human being who's using the drug, is different. They are related, but I agree with you. And, the stigma even exists. I remember markedly when I was involved in patient admission issues and talking with clinicians to this day, that even within the patient who was using the drug, they created their own class distinction. So one would say, oh, I'm snorting it, but I didn't get to inject it yet. Because when you're injecting the drug, oh man, you have a real problem.
Yeah.
So they created this sort of interesting system of how they would self-categorize. Once I know I'm injecting, I'm in real trouble. And so that's what was so interesting to me, is I remembered those patient voices. And when I heard that 30% of the people using opioids were injecting them, I thought, well, that's a big change. Something is happening. I think that, from my point of view, there has to be an explanation to this country of how we deal with this issue, that people, have real issues going on in their lives, and that you shouldn't be saying to people, you use this drug, therefore you're bad, or you're not moral, or you're not responsible. I think that I would think, as this continues, that there are so many people from all walks of life using opioids that ultimately it changes, and frankly, there's a mixed issue of if as more people who are in the public realm talk about these things, I think that changes matters too. But this issue of stigma and changing it is so complicated that I'd like to see it change, but I think that we're going to be heading into the next generation to actually bear witness to some of these changes.
I just hope we don't cause damage, and I fear that we're making the problem worse with good intentions. When we don't want to be able to say using drugs is bad, the use is bad. You're not a bad human being, but that's a bad habit. You know, we all have different bad habits, right? You may have a chemical imbalance, brain disorder, but it's something that, you know, that you don't want.
No, I understand it, and I agree it. I think it's trying to explain this the more differentiated judgments are, the more difficult it is to get people to understand what you're talking about. Because you have to explain, and you know, it's an interesting thing. If you have to explain too much, people lose their patience and their attention. It's like, oh my God,
right.
You know, what are they telling me?
Right.
Like, this is like,
I need it in a meme. Just
right,
a
it's
short.
like, you know, can you look? You know this in your work. I remember when someone would say to me, "Look, this is a great report, but it's 25 pages. Can I get the one-page summary?"
Yeah.
And the answer is, sure, you can get the one-page summary, and I'll write it in such a way that it'll be a teaser. So you want to go back into that 25-page report.
Yeah.
Or someone would say, that was a great protocol you wrote and put on your website about how you deal with hub and spoke models in the States. But it's like a 60-page paper. Yes. Well, you know, that's hard to read. I said, I understand. I had to write portions of it and edit it. But I understand. I said, look, it's not written for you to read that thing around a pool with a pina colada. You have to read the thing in a brightly lit office with some coffee or other reasonable, like tea, stimulant, whatever. Yeah. But you have to do that. So, you know, I think that it's, you know, it doesn't mean it shouldn't be done. And I think that we as advocates clearly need to constantly be at this. In terms of, even in all of my congressional work, and I'm talking with so many congressional staff, no matter what the topic of the bill happens to be, you inevitably get into a discussion of, tell us the difference between methadone, buprenorphine, and extended release naltrexone. Explain what the drugs do differently. Explain how long you should be in treatment. Explain what other parts of treatment should exist. It's a constant education. Yeah. And these are among people who write our laws.
Yeah, I know. It's scary. Being in DC, it's scary about who makes our laws and how much knowledge they have in doing that. And with that, I really want to say thank you to Tara, who works in harm reduction. I so admire the work that you do, the passion, the heart that you give of yourself into giving back in the community. And Mark, this has been an absolute delightful conversation. I wish we had another hour, and maybe I need to go visit you in New York for dinner so we can continue this conversation. It is enlightening, and really, I think the organizations you represent and the OTPs are really blessed to have your longevity, knowledge, and you clearly know what's going on from top down and all around in your field. It's been a pleasure talking to you. Thank you.
Well, it's good seeing you. I'm glad we were able to reconnect, and I look forward to when you come to the East Coast so we can get together.
All right, great. Thank you. Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support from our sponsor. A sincere and warm thank you to FAF, Families Against Fentanyl. Visit familiesagainstfentanyl.org and sign the petition to declare illegal fentanyl a weapon of mass destruction. Make drug dealers think twice and 3 times before peddling killer drugs. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.